Uh, Thank you. You've just had a treat. You've had a very interesting talk from one part of the country, difficult area, and wonderful work. And I can assure you, you're going to have another treat from another part of India by Dr. Ajit. Is Ajit here? Yeah. Oh, hi. Okay, so if I can borrow from um, Dr. Vijayanand's term of phase one, phase two, phase three, I guess you're in your phase four of your life. I think Ajit is in phase one of his life, and he's going to talk to us about equitable healthcare in Gudalur Valley. Ajit has studied in the famous medical college at Thiruvananthapuram, Trivandrum, as many of you know it. And then he's worked in Gujarat, Jammu and Kashmir, mostly with government related service NGO. And then he's moved to Gudalur since 2022. So over a year. Without much ado, handing over to you.
Thank you so much, Dr. Sushil. Frankly speaking, the vantage point from up here is quite scary. Because there are so many experienced people, so many people who have actually inspired me to come into this, standing there listening to me. And I am metaphorically shitting my pants right now. Yeah, so anyhow, I'm in phase 1.25 right now. The first phase was set out to be a doctor, a clinical doctor. And then, I kind of pivoted into community health because I had a stint with Gudalur Adivasi Hospital, the hospital managed by Ashwini, in 2017. And I kind of, started enjoying the work that was happening in the Adivasi community there. And I did my MPH in Gandhinagar and then worked in a tribal health organization there called Seva Rural in South Gujarat. And then thought that, oh, this NGO business is all a sham. I went into United Nations development program for a year and then thought that the UN organizations are a sham and came back. So, yeah, so this is full circle, I think. So without much ado, I just want to introduce you to the model that, we have in Gudalur. The evolution in a brief introduction into the kind of journey that the organization had and various determinants as as an organization would have actually addressed it in terms of economy, in terms of health, in terms of geography, various determinants that can actually like contribute into equity in health. Having said that, a large part of equity in health in Gudalur from experience had been equity in healthcare. We are still trying to figure out the larger aspects of equity in health. So, yeah, that's that. Just to give you a context of the communities that are there in Gudalur Valley, we are talking about two, taluks in the Nilgiris district of Tamil Nadu, which kind of borders with the northern part of Kerala and the southern part of Karnataka. This is approximately 100 kilometers from Mysore and 55 kilometers from Ooty, maybe a 35 kilometers from Wayanad on the Kerala side. We have a Paniya community, which in Malayalam and Tamil roughly translates into a laborer, who is 58% of the total tribal population, and who have been bonded laborers in the time of the British, but later on became informal bonded laborers in the time after independence. Then we have Betta Kurumba community. In Kannada, Betta Kurumba community means the forest dwelling people from the hills, from the mountains. They are the ones who are traditionally in the elephant rearing profession. Now, large majority of Betta Kurumba community is working as manual laborers. Then we have the Katanaikan community, who is evenly distributed across the northern part of Kerala and the south of Karnataka. They are also known by small variations in the name. But Katanaikans in Gudalur are primarily foragers. They are the ones who forage honey, various other non-timber forest produce from the forests and live in the most proximity to the forest. Then we have the minority, the Malayalam-speaking Mullukurumba people, who are traditionally irrigated farmers, who basically are into paddy cultivation or various other forms of cash crops, who are more, living towards the Wayanad side of Kerala. And Mulukurumbas, out of the 4, are also slightly better in terms of land ownership, in terms of educational opportunities, and various other factors of social capital. And this is a brief history of what had been happening before, the organized movement started in Gudlur. Many of you might be familiar with it. In the early 80s, from inside the tribal communities, there was an uprising of sorts, primarily to fight, the encroachment of land, primarily by various private estates and the government, because the government was starting to claim a lot of the forest land as nationalized forests, where tribal communities were not allowed to stay, and from the one side, the estates were actually pushing people outside. So there was a lot of forest land was being converted into tea estates, and a lot of people were evicted from those tea estates, either by hook or crook, or people would just use muscle to get them out. And then there was another demographic phenomenon that was happening in Nilgiris. In the early 80s, a lot of Sri Lankan refugees also started coming in because of the ethnic conflict in Sri Lanka. And now, if you look at the population of Gudlur, in the two taluks that I'm talking about, Gudlur and Pandalur taluks, we have close to 2 lakh people in total. And the tribal community members come only up to 22,000. So it's a little around 10% of the total population. And earlier times, when people were having enough of like getting evicted from their houses, or their houses being torn down by the police, they started, coming together despite all the hierarchical differences that they have between these tribal communities. And there were a lot of tribal leaders who were trying to actually look at, this whole movement, looking for a leadership. And that was a time when a couple called Stan Tekekara and Mari Marcel came into Gudlur and started an organization called Accord. This was the mid 80s. And then they kind of started a movement with a lot of tribal members there, like K.T. Subramaniam and Bomman, who kind of, orchestrated a big organized movement in Gudlur town, which, as they mention it, when they went for protection with the police said that, you will have less than 20-30 people. Why are you asking for police protection? And it ended up witnessing around 10,000 people in the town, marching together for their land rights. And that was the first pivotal moment when the government and the machinery actually started noticing that Adivasis can actually come together. Adivasis of South India can come together and ask for their rights. And then from that point onwards, that organized demonstration happened in December 5th. We celebrate that as Adivasi Day in Gudlur Valley. And that evolved into Adivasi Munetra Sangam, an organization which has this insignia of bow and arrow and cultural artifacts of these respective communities. Kind of is the umbrella organization under which various other organizational or community needs have come together and all that. And the first thing that they did was reclamation of land. A lot of land which was previously encroached in by the private estates were recovered primarily for establishing villages, establishing their own small cultivable land and all of that. And then once they started getting into, the groove of like owning land and starting small tea plantation, because tea was also a strategic move. You don't call a tea planter as a farmer, you call them as an estate owner. So strategically, the Adivasi communities in Gudlur went from being estate laborers to estate owners. And in all those white collar meetings where estate owners across India would come, these Adivasis would walk in and claim their space and establish a kind of a changed social norm and, ask for what is rightfully theirs. From that point onwards, they pivoted into various developmental needs. The first of the needs was addressed by the creation of formal systems under Accord for land reclamation, for economic development, for housing. And then there was also this felt need from the community that, okay, we have been going through a lot of adverse experiences in terms of healthcare utilization. So can we all come together and form a small community health related venture? And the reason why they thought about that was, as you can see, the immunization was quite low. Very low number of women were actually able to seek medical care. there were insurmountably high levels of deaths due to diarrhea, anemia, tetanus. Eclampsia was higher in incidence. So in the beginning, two medical doctors who had just passed out from CMC Vellore had come there just for an orientation and experience, Dr. Devadasan and Dr. Rupa. They started a small community health program there and started training people from the community, first in that leadership wing, where people were already like in a slightly more oriented, slightly more motivated sense. They all got some basic training in primary healthcare, identification of certain danger signs, and getting people to come to the government general hospital in Gudlu town. But what happened was, later on, somewhere in the 1988, 1989, in a month, a series of 4 or 5 deaths happened, antenatal deaths happened repeatedly after, being denied of timely healthcare in those government hospitals. 4 deaths happened in 1 month due to eclampsia, primarily because there was a prioritization of non-tribal patients over tribal patients, and tribal patient actually had to wait. One of the women actually passed away on the doorstep of a government hospital, and the community again came together and said that, listen, this community health program is good, but we need a physical infrastructure to have people housed in, where people can actually feel like they can actually claim that space and all of that. That led to the creation of Gudlur Adivasi Hospital in 1990. And another couple of doctors, Dr. Nandakumar and Dr. Shaila. Dr. Nandakumar is an alumni from CMC, who were instrumental in creating that kind of a physical infrastructure and kind of giving it a shape and form. And the reason why it was a different model at that time was because there were a lot of cultural practices which were adapted into the hospital practices. Like, the people in the community were not accustomed to having, having experienced a hospital bed. And you might be knowing that hospital beds are unusually taller than normal beds that you have at home. And for people who have not been experienced sleeping on a bed, it is even more difficult. So we never had beds to begin with. We had, the doctors would come and like sit next to the patient, and the patient would be lying down comfortably on a charpai like thing on the ground. And later, slowly, we graduated towards lower, slightly more convenient beds for the patients. And we didn't have like a male and a female ward separate, because in the community, there was no such difference that males would be hanging out together and females would be hanging out together. We never had the concept of a pay ward as such, because we knew that anyways, that is not going to be used. And the non-tribal community members who would eventually come and use these services should also be housed inside the same room to somehow challenge the social norms. And one naughty thing the founders had done at that time was, any non-tribal who wanted to come to the hospital needed to get a small memo-like thing from a tribal leader to come to the hospital, just to challenge the social norm, so that they will have to go to the very same people that they used to avoid or despise. But later on, we kind of like did away with that particular practice, because the hospital also came from the tribal community members, the leaders. They said that no, we don't want to be this naughty. We know that people will start using this service more, so let us not make it inconvenient. And just to touch upon various aspects of equity, and just group it roughly around, the sense of economy, the aspects of environmental safety, the aspects of agency, aspects of service. I must say that the model of healthcare had evolved in such a way that it has been around mostly empowering in terms of agency or giving appropriate services. The economic and environmental safety parts were by and large addressed by the sister organizations. So because I'm coming here on behalf of the healthcare model, I will not be a good authority to talk about those aspects, but I would touch upon various things that had been happening as part of addressing the equity related aspects of healthcare. And the various points that I've mentioned here are just pointers, and many of the people who have spoken before me had actually touched upon all these points about how informal wage labor has actually destabilized the purchasing power for healthcare or the agency around healthcare, how various indigenous communities have not been able to use the same kind of rights that other people have, because they are living in close proximity to the forest, and they are primarily their land rights are overlapping with forest rights, and how Forest Rights Act have made it very difficult for them to access the same set of rights. And because most of the economic factors are also coming from these forests, how these things overlap and intersect to make it much more difficult for these people to actually get their income or economy from that particular thing. There is a large majority of tribal youth who migrate to various parts of Kerala, Tamil Nadu, and Karnataka in search of better economic options. And they invariably end up embroiled in some kind of a cash incentive in form of alcohol, some kind of adverse conditions of work. And they end back in Gudalur, they come with some kind of a lifestyle illness, some addiction, some amount of mental stress, and mental health related problems. A lot of animal-human conflict in Gudalur Valley, because it's also partly an elephant corridor. Half of Gudalur actually comes into a, it kind of like intersects into a wildlife sanctuary. A lot of human-animal conflict happens, and that also becomes a big challenge for people to either access various services which are in the mainstream, which are in the cities, in the town side. At the same time, it also kind of creates a very hostile environment in their village. And when Adivasis come and complain about animal-human conflict, even the authorities are not very serious about looking at those kind of things, because they automatically start calling people that, okay, you were given an option to relocate from the place where you're living, then why are you complaining? Now you have actually chosen to live in a hostile environment. You have no right to complain. And then when it comes to water and sanitation and hygiene, we know that a lot of big programs had actually been able to connect these villages with better water and sanitation hygiene practices. But whether the taps will run, whether the toilets will be completed on time, whether the toilets actually have a roof, whether various other supporting factors will be in place is a big question that we all have to ponder upon. So macroeconomic policies also have the same way. When it comes to the implementation, there are various gaps which kind of make it a little inequitable for Adivasi communities, especially in a place where the community is by and large invisible. The mainstream Gudalur is extremely urban, extremely touristy. When people pass through, they don't see an Adivasi village. They have to either descend down a set of stairs or climb up a hill or go through an extreme thick vegetation to actually go and see a village. So the Adivasi villages are nowhere seen. They are completely invisible. It's not like a cul-de-sac as such. Then when it comes to nutritive, reproductive, and child rights, many of the programs, including the public distribution system, has been consistently avoiding or consistently blind to the various nutritional nuances of tribal communities, because most of the nutrition used to come from the forest, and they were extremely rich in various micro and macronutrients. But when it came to the PDS, it was completely homogenized into 35 kgs of rice and 1 kg of dal for a family of 15. So it becomes really tough for the family to go into a diverse, nutrition-rich kind of a diet. And then what happens is the supplementary nutrition systems like ICDS and all of that are again perpetuating the same rice-rich kind of a meal, which is okay for a non-tribal community member because the family already has the awareness or the practice or the economy to buy various other nutritive products. But for a tribal community member, it's just two times rice-rich meal, either maybe with a spicy chutney. That's the nutritive source that they have for both adults and children. When it comes to child rights, a lot of rights and regulations are a little hostile towards Adivasi cultures, especially the POCSO and all of that, because there is a lot of persecution that happens even in cases where the cultural sanction is there for marriages where children are a little more than maybe 16 or 17. Just because they are not 18, they are not considered as an adult in the eyes of a legislative system. But the culture has actually sanctioned that, okay, two people like that can actually fall in love and get married and consummate marriage. And then later on, what happens is the police will come and take them away, treat them like they have done a criminal offense, and then the minimum punishment for that is like 20 years and all. In a lot of ways, these supporting systems, which are supposed to be an enabling environment for equitable access to health, becomes hostile situations, which kind of further strip them down of various other factors. These are a few challenges. I have actually mentioned many of this. And when you look at the healthcare itself, we have high burden of suicides. In fact, suicides is a third biggest cause of death. We have a reduced health seeking behavior, and we also have seen the tribal leaders have not been able to tell their children the struggles that they have withstood against and the things that they have done. And because of that, there is a clear lack of vision, lack of motivation in the younger generation. And we have various organizations which are addressing to various developmental needs coming together in a 3-tier model in Gudalur, where we have community animators, health animators, education volunteers, all of them coming together to work in these satellite centers called areas. One area catering to like 15 to 30 villages. We have altogether around 320 villages. And this is roughly a model where, the healthcare has actually evolved from a community-oriented health volunteer model where the self-motivated people from 1 or 2 villages come together and they say that, okay, we can actually like coordinate few healthcare activities here, to trained nurses who are salaried staff, somewhat like a village health nurse or a ANM. We have 18 of those. We call them health animators. And then we have the program staff, much like me. And, we have something called a community insurance, which had started in the 1990s, which kind of gives a small umbrella-like protection for each family. And the family just pays like 500 rupees a year, however big or small the family is. And a basic community level safety net that is there to protect. And whenever there is a problem, either it kind of comes out through these routine screening visits that happen, or when the health volunteer come in touch with the person, they get to know that this person is actually going through some kind of an adverse health situation. They alert the health worker, and the health worker organizes for that person to either be taken care of in the village or be taken to the Adivasi hospital. And then if the problem is not addressed there, we actually take them to the nearby referral center. If there is total recovery, they go back. If there is a little more recovery to be attained, they go back to the hospital. And from the hospital, they go back to the village. Post-discharge, information is passed into the health animators group, and then they follow up them in the field. This is the circle through which the patients go through. And when we talk about various aspects of healthcare related access, we have a field-based monitoring system where each patient has a Sangam number, which is a unique ID through which all of their healthcare is tracked properly. And we have a app-based follow-up. And then we have some kind of a cultural acceptance, because 85% of the staff is from the community and they speak the same language. To that, the specialists actually go all the way from the hospital, the physical infrastructure, to the people to actually understand and kind of appropriate the kind of experiences that they have in the village into the healthcare plan. There is also a lot of infrastructural thing, like we don't have a mobile medical unit as such. Most of these systems work through the area centers. So there is a physical infrastructure where the people also can come. There is also, in terms of time and transport, we operate in times where they don't have to sacrifice on their day labor or their cultural thing. Affordability, like I mentioned, there is already a system of health fund. Insurance is very difficult to convince when the government also runs an insurance model. So we have changed it into a health fund now. And these are the ways in which we have tried to address various aspects of health promotion. I don't want to go into the details. Now, the ownership and decision-making primarily happens through democratic processes, which happen through a staff board. There is an executive committee, there is a working committee, and then there is a machinery similar to that in the village level. These village level leadership actually is groomed by the senior health volunteers and health animators who are already a village leader in their own respects. And all of this kind of ties in nicely into the umbrella of the Adivasi Munnetra Sangam. So there is always this free-flowing exchange of ideas and conversations and all, which happens from the tribal leadership. These have been a few of the things that we have been able to achieve in the last 33 years. We have been able to bring down the maternal and infant mortality from 100, 150 to right now. The last year, the infant mortality was around 21. Maternal mortality, we had 1 maternal death in the last 2 years. There's a few other signs of progress, increased hospital deliveries. Work participation of women is more. Around 79%, 89% of our staff is women. 79% is from the tribal community. few of the pictures. Whenever there was a problem, there would be a solution that would come from these discussions that we have.
Ajit,
this thing.
Ajit, I hate to interrupt, but you need to wrap up.
Yeah, just a moment. Just to kind of bring to you these few nuances about the healthcare, this thing. Merely having an infrastructure doesn't help, but when the infrastructure is run by the community, it helps challenging the social norms. We have to also be mindful about how Adivasi communities have been actually like experiencing the change around them, and how we can actually bring them as an equal part stakeholder. Understanding geographical nuance in a way where there is a ICDS center in 1 kilometer radius, but because there is a hill in between the ICDS center and the village, the access to the ICDS center might be low. So these kind of geographical nuances have to be talked about and thought about. And community spaces and housing. This is a government house which is completely leaked after 3 months of construction during the heavy monsoons of this thing. Yeah, that's it. Thank you.
Thank you. Thank you, Ajit. If you hadn't told us, I don't think anyone would have thought you're tishing your pants. So good presentation. Thank you for that. Now over to the audience. I think I have got a few questions. You're welcome to send in more. It's a question: how do the government programs contribute to the equitable growth of the Adivasi community in Gudalur?
Yeah, so there are various ways in which the government programs are, helping us. One is the Chief Minister's Comprehensive Insurance Scheme. We are one of the empaneled hospitals, and we try to get more of the tribal community members get the insurance coverage. That way, a lot of the healthcare cost is cut down, both in the Adivasi hospital as well as in the government hospital or any referral center. Another thing is there is something called as a tribal bed grant. For each tribal admission, 3,000 rupees is given for for the cost that is cut by the hospital. Then various other schemes like tuberculosis elimination program and all of that, we kind of have handhold with the government. But in a lot of other aspects, certain programs like ICDS and all, we are struggling to actually have that same kind of partnership and all. In fact, ICDS centers are poorly managed. Nilgiris is considered as a punishment district for many of the government cadres. So the people who come there to Nilgiris to work are primarily not in a mind space to work. So it becomes really tough to handhold in, say, various programs like nutrition and maternal and child health.
Okay, two interesting questions. Have you faced any opposition from the tribal community? And the second is, do you see any of the younger members or any members wanting to take up medical courses?
Yeah. So one of the things that I actually put up in a slide is a picture of a nursing school that we have. We have close to 120 people who have actually graduated from those from that course. We also have a public health graduate. We have a couple of people who have graduated with MA development. We have not yet gotten a MBBS graduate yet, but one Pania boy has actually enrolled into one of the medical, I think CMC only this year. So in 5 years' time, I think we'll have a doctor also from the community.
Does the Adivasi Munetra Sangam participate or engage in the decision-making processes of the government in matters affecting them?
Yeah, mostly it is firefighting. Whenever there is a litigation, whenever there is a forest rights related thing, we kind of go and meet the government machinery and try to address various complaints from the community side to the government, kind of be a front end of the community to the government. Whether we have worked together, yes, in various implementation of like some welfare schemes and all, which comes to Nilgiris, especially in the environmental safety space and all of that, the organizations are actually coming together with the government and working. Some of the bureaucrats have been really nice, like Dr. Darius yesterday. He was earlier working in Nilgiris and had been instrumental in various certifications and all of that. So Mr. Priya Sahu, all of these people have been extremely instrumental in helping us at various points.
Okay, this is the last question. You work closely with the Adivasis. What is their perceptions about themselves as a people when compared to non-tribals?
Adivasis right now, I mean, I can only talk about the generation that I belong to or the younger ones. There is definitely a sense of identity crisis that they are going through. They don't want to tell people that they belong to a particularly vulnerable tribe. And because of that, identity related discussions are really difficult to crack. At the same time, there is also a sense of privilege with which I walk into such conversations. And many of us, we kind of like engage with them, trying to understand, looking at it from a virtuoso lens. And they might not be, the Adivasi community members might not be looking at this particular subject from that same lens. To actually build a space, you have to continuously engage. And we have various youth initiatives in Gudalur. One of them I want to mention is called One All. It's an intervention using a sport, ultimate frisbee, to bring young people together and talk about gender, health, power, identity, and all of that. And this organization kind of uses these various soft skills to kind of bring Adivasi youth together and discuss about identity. Identity is a problem. It is a difficult nut to crack, actually.
Okay, thank you. I'm in one of the objectives is to try and inspire young people, and so I will step over the line, and any young person who's would like to ask a question, you could. I'll have to stop asking these questions. I'm sorry, but I don't mind any of the youngsters who you just had two back-to-back inspiring talks from a senior citizen and a 1.25 phase person. Yes, go ahead.
Thanks for the talk, Ajit. How do we inspire people to work in places like that? Now, the whole idea is you do MBBS, you prepare for NEET, MD, you get in. People are not getting exposed to this. So, how do you attract people, youngsters, to work in such places?
So we have a program called Rural Sensitization Program. We basically get students who are in training or who are already finished with MBBS to come to places like these. Places like Gudalur, Sithilingi, basic healthcare services in Udaipur, Lindsay's place, JCMB in Bokaro. All these places, what we are trying to do is we're trying to give them a piece of the experiences that we all go through on a daily life. And if they are inspired, they will jump into the bandwagon. We have something called a travel fellowship also, where there is a year of time allotted to interested people, selected interested MBBS graduates, where they can go and work in such organizations for a period of 2 to 3 months and experience it by themselves and choose whatever or wherever they want to work or continue. Okay, thanks, Parth. Thank you so much for this opportunity. Thank you.
I'd like to invite our moderator to give a token of our appreciation to Dr. Ajit.